Thank you for inviting me to speak today about the work of the Childhood Dementia Initiative. It's lovely to be here, and I'd also just like to echo the acknowledgement of country that was said earlier. Okay. Today, I'm going to talk about the challenges and opportunities in clinical trials and research, and also give an update on the care and support projects we're working on, and a bit about an advocacy update as well. So last year when I presented to this conference, I talked about the childhood dementia burden study that we had just submitted for publication. And I'm pleased to say that it was published in the journal Brain, which is great because that journal has a wide reach and it has brought a lot of attention to childhood dementia. So just a reminder of the top line results of the study. So we curated a list of 145 genetic conditions that cause dementia in childhood. And when you bring all them together, it affects 1 in 2,900 births, which was higher than we even expected it to be. And it's on a par with cystic fibrosis, which everybody knows about. There's a lot of variability in the average age of onset and the life expectancy, but the average that was calculated was onset around 2.5 years across all the conditions and a median life expectancy of 9 years, but a lot of variability in that. Since the burden study gave us a clear view of the incidence and prevalence of childhood dementia and what conditions cause childhood dementia, we used this information to recently do a global clinical trial landscape analysis. We focused on clinical trials because they are the only opportunity for the vast majority of children with dementia to potentially access a treatment that might slow down their disease progression. In our analysis, we compared childhood dementia research to childhood cancer. So why did we do that? Well, not everyone knows this, but childhood cancer is a group of rare conditions like childhood dementia. And both childhood cancer and dementia are serious and devastating for families. You might be surprised to hear that both groups of conditions cause a similar number of deaths each year in high-income countries. So here in Australia, we estimate that about 91 people die from childhood dementia each year and 92 die from childhood cancer. And this is replicated in countries like the UK and the US. So what did our analysis find? We found a real inequity that spanned over the full 23 years of data available in clinicaltrials.gov. What does it look like currently? This graph shows how many trials are recruiting per patient with dementia or childhood cancer. And globally, there are 24-fold more trials recruiting children with cancer than children with dementia. Of course, we want to see more childhood cancer research, and we celebrate the advances that are being made for childhood cancer. To be clear, we don't want to see less childhood cancer research, we want to see more childhood dementia research. And beyond this inequity, we found some other concerning trends that research is actually slowing down. So this graph shows the number of new trials registered in clinicaltrials.gov since that database became public in the year 2000. And you can see in the dark blue line, that's all of the clinical trials registered for all conditions, and that's continued to increase. But over the last 5 years or so, the number of new trials for childhood dementia has sort of plateaued off, which is a concerning trend. There may be many contributing factors to this, including the pandemic and the downturn in global economic market, but you can see that the number of trials registered for other diseases continued to increase. And with all the technological advances in genomics and drug development, we would expect and hope that the number of clinical trials for childhood dementia would be increasing exponentially right now. And unfortunately, the story only gets worse. We scanned recent press releases and found worrying evidence of trials being started and then halted, despite positive results and no safety concerns. This was especially true for expensive therapies like gene therapy. We found 10 examples of this, and they're listed in the report if you want to have a look on our website. There are likely other examples, but it's difficult to identify them. 9 of these trials were still listed as active in clinicaltrials.gov at the time we did this analysis. So the graphs that I showed you on the previous slides actually overestimate the clinical trial activity for childhood dementia. We also found another 5 trials that failed to initiate at a very late stage. So after natural history studies had been undertaken, the drugs have been manufactured and toxicology studies completed. And reasons for these failures include regulatory barriers and commercial issues. We've heard about the need for longer trials, denied access to accelerated approval pathways, and regulators demanding unfeasible clinical trial designs. This makes trials more expensive, and ultimately companies, especially small biotechs, can't continue. And the end result is that promising treatments are shelved, which is outrageous. It's ethically wrong, heartbreaking for families, and incredibly wasteful of decades of research, mostly funded by patient organisations and governments. And now I'm going to turn my attention to the Australian clinical trial context. So of the 54 trials that were recruiting at the time we did the analysis at the end of last year, only 2 were recruiting in Australia. By contrast, in Australia, all children with cancer are eligible for at least 1 clinical trial. The 2 trials that were recruiting for childhood dementia in Australia, because of the narrow eligibility of those trials, much less than 2% of children diagnosed with dementia have a chance to take part in a clinical trial in Australia. So we need improvements in clinical trial infrastructure and clinical capacity to do more trials in Australia. We also looked at the amount of research funding that the government is allocating to childhood dementia. And we found that since 2017, there's been almost 5 times more funding allocated to childhood cancer. It's anticipated that this lack of research funding for childhood dementia is replicated around the world. And this is due to the lack of awareness of this group of conditions, which have traditionally been seen as individually rare conditions, rather than grouped together based on their similar clinical presentation. And this historic and ongoing lack of research funding is contributing to a global lack of clinical trials and subsequently extremely limited treatment options for children with dementia. Now, there are opportunities all along the drug development pipeline to address barriers that I have talked about and to increase the availability of effective treatments. The regulatory barriers that have been a hot topic of conversation recently, particularly in the US with the FDA, and there's been some progress in that area, so we hope that will continue. And now this is a graph from the Swedish Childhood Cancer Foundation, but the pattern is replicated in high-income countries around the world. And it shows the impressive gains in survival over the last 50 years or so for childhood cancer. In Australia, for childhood cancer, the survival rate is now well over 80%. And there's been no such improvement in the survival for childhood dementia overall. If the data were available for childhood dementia, it would be barely visible along that 0% line at the bottom. But we would like to be able to show a graph with improvements like this for childhood dementia in the near future. And I think NPC is trailblazing the path with some of the progress being made that I'm sure we'll hear about in the next few days. Some other opportunities to improve the research and clinical trial landscape for childhood dementia include looking at disease mechanisms in common between childhood dementia disorders to get greater economies of scale, and also shared with adult dementia. And I think Tony's going to talk a bit about some of this in a little while. Also platform technologies and infrastructure sharing so that research on individual disorders isn't happening in silos and replicated time and time again. I think we can be much more efficient than that. And of course, we need more research. That's what I always talk about, more research for funding, and I'm sure the researchers in the room would agree with that. So changing tack completely now, I'm going to talk about the broader work of the Childhood Dementia Initiative. So this is the Venn diagram that we always show to give an overview of the work that we do at CDI. You can see that all of our areas of work are interlinked and converging in the centre there on treatments and cures, equitable and quality care, and making childhood dementia a health policy priority. So next I'm going to take a breath and play a video. Mark Butler. This is a video that we received earlier this year.
Well, hello, I'm Mark Butler, the Minister for Health and Aged Care. This year, the Albanese Government is funding an exciting new project with Childhood Dementia Initiative called the Childhood Dementia Support for Consumers and Health Professionals. This project will look into the unique care and support needs of children with dementia and their families. The impact of caring for a child or children with dementia is immense. We know from families that children with dementia don't fit within the established systems of health, disability and social care. And this means that it's difficult for them to access the support their children so desperately need. To change this, we need information from families about what isn't working and what is needed. We also need insights from health professionals and service providers about their experiences in this area. Childhood Dementia Initiative will be undertaking many consultations across these various groups. The first of which will be with families in a world-first psychosocial impact study in partnership with the University of New South Wales. By contributing your valuable thoughts and experiences, your voice can help us understand how to build care and support solutions that are appropriate, equitable and sustainable. This will help improve the quality of life of children with dementia and their families for generations to come. The Albanese Government congratulates Childhood Dementia Initiative for their work in this area, and we appreciate your contributions to this important project.
So, oops, we don't want to hear it again. Once was enough, thanks. Okay. So I'm going to talk about these projects that the government have given us funding to do. Our team member Ellie de Ross, who is leading this project, provided these slides to me. So thanks, Ellie. So we were fortunate to receive some funding from the Department of Health to look at the care and support landscape for childhood dementia, map out the gaps and work towards solutions. Most of our previous research has focused on the lived experience of families. So in this project, we'll be engaging with a wide range of professionals from medical, disability, community care and researchers to understand what barriers they face to providing better care and support. This year is about fact-finding and next year will be about exploring the solutions. This is the project team. We have engaged Health Consult to carry out this consultation. Many of the team members at Childhood Dementia are involved in this project. The Professional Experience Advisory Group has Nick Smith and Michelle Farah participating, and many of you may know them. And we also, very importantly, have the Lived Experience Advisory Group. Their voice is very important because they experience firsthand the broad spectrum of services. This is the project timelines. We're now at stage 4, conducting interviews and focus groups with a broad range of stakeholders, and we've also launched a survey. The next stage will be drawing out principal themes, what's actionable, and aligning with existing national and state policies in related fields like dementia, chronic disease, and rare disease. High-level findings, which will be probably of no surprise to the families in the room. So the current childhood dementia care and support environment is highly fragmented and variable. Stakeholders commonly raised a lack of knowledge and the absence of accessible information as major barriers to care. A well-defined and structured model of care or best practice remains elusive, both in Australia and internationally. And the involvement of a multidisciplinary team was commonly raised as a potential solution. And that last point I've already talked about, that's the lack of clinical trials and research. Potential gaps identified across many areas. None of them will be a surprise. Things like lack of access to new therapies, lack of centralised resources, lack of an awareness of childhood dementia, poor equity of access, care funding delays, and so on. So the health professional survey is now live as of this week, and it's been emailed to all of the health professionals in our database. But please tell any health professionals working in this space about it. And there's a QR code there that goes to the survey. And we're looking for any health professionals that work with children with dementia and their families, from paediatric neurologists, counsellors, social workers, nurses, all of allied health, palliative care, and so on. And we hope to have all of our responses in by the end of this month. And moving on to the psychosocial study, which Mark Butler mentioned in his video, that's all part of the same funding. Families tell us that childhood dementia has immense impact on multiple fronts, including psychological, social, and financial well-being. So the childhood dementia is partnering with researchers from the University of New South Wales and the Sydney Children's Hospital Network to understand the psychosocial impacts of caring for a child with dementia. And we got the funding from the government to do this, and we're seeking parents and primary carers who are bereaved or who have a child living with childhood dementia to do the survey. Participation involves completing a 10-minute survey, and there's also an optional follow-up interview, and both parents can complete the survey. There's the famous QR code to the survey for families. If you don't get it up on your phone while I'm up here, come and speak to me and I'll get it to you. Many of you may have already done the survey, and thank you so much for doing that. The quantitative and qualitative data that we get from this study will be converged to generate a robust and rich body of evidence to inform healthcare and psychosocial services. So it's a very important study. And I'll just leave that up there for a second in case anyone... No? Okay. Just one final slide on some of our advocacy work. Across the world, childhood dementia is not a health policy priority and is not included in dementia policy. Only Scotland's dementia strategy released last year mentions childhood dementia, but children will be included in Australia's National Dementia Action Plan, due to be released this year. And we are working and advocating for dementia to be recognised as a lifespan disease, including children, and for them to be meaningfully included in policy. So look out for that later this year. I think it's going to be really impactful. So just finishing up, I'd like to acknowledge all of the team at Childhood Dementia Initiative for their input into all of this work, and also our Scientific and Medical Advisory Committee who guide our direction. My email address is up on the screen there if you have any questions that come to you later. And we have resources, information and ways to get involved on our website for families, researchers and health professionals. And that's our web address there. Happy to take any questions.
Yes, go ahead, Lisa, with your question.
Hi, Lisa.
So can you hear me?
Yes.
Great. Hi, Chris. Thanks for your presentation. I wanted to ask, in your analysis of clinical trials, for everybody else in the room who doesn't know me, I'm Lisa Melton from San Filippo Children's Foundation. I'm here in Sydney. So in your analysis of clinical trials, I wondered how many you had seen or what analysis you'd done of clinical trials that involved more than one childhood dementia at a time, and whether you learned anything in that analysis about some of the regulatory issues or protocol issues that face multi-disease trials, and what we might need to do more of those.
Yep, good questions. There were only a couple of trials that included more than one condition, and one of them I think we might hear about tomorrow it includes Niemann-Pick. And then there was a bunch of trials that were doing bone marrow transplants, and that included a wide variety of metabolic conditions. But other than that, there wasn't really very many. In terms of regulatory issues with including more than one condition, we didn't come across anything. And looking further into regulatory issues was something that we have been thinking about as next steps, because that data that's not really available in the databases, or it would require a consultation with individual companies and researchers to find out, to really document those issues. Does that answer your question?
Yes, that's great. Thanks, Chris. I think that would be a really interesting exercise to do, to explore that a bit further in terms of consulting with people that have done multi-disease trials and look at those issues. Yeah, great. Thank you.
It was great news last week with heparin sulfate being accepted as a surrogate marker for the San Filippo clinical trials and accelerated approval. So that's one of the steps forward that we've heard about recently.
Yes, very exciting news, and it's going to make a really big difference to the field for San Filippo and other diseases that have heparin sulfate as a potential biomarker. It's hopefully a bit of a pivotal point for us.
Yep. And also leading the way for even other diseases to really get those validated biomarkers to speed up clinical trials. Any other? Kim? One of the big barriers is one that we can't do a lot about, is just the small population, meaning that there's not very many patients. So companies may favour other countries where they can recruit more patients to one site. But beyond that, there has been a lot of talk about the need for a paediatric clinical trial network in Australia to really increase efficiency and really make Australia really attractive clinical trial destination for these often complicated trials, especially with advanced therapeutics in children, and to also enable that recruiting of patients from all over our big country for rare diseases.
Mine's a very simple question. I didn't understand your reference to heparin sulfate. Could you please?
Heparin sulfate. So in Sanfilippo syndrome, the children are missing an enzyme that breaks down a complex sugar called heparin sulfate. And you can measure heparin sulfate in the cerebral spinal fluid. And in the clinical trials, they've been able to show that the amount of heparin sulfate building up is reduced. And they've been able to convince the regulators that that's a good enough indicator that the drug is working. And they're allowing approval to be at least partly based on the levels of that sugar in the fluid. And the alternative is to measure the cognitive abilities of the children after they've had the treatment. And that can take a really long time to show, especially if you treat the children young when they need it. It can take 5 years or more for them their cognitive development to deviate from the natural history of the disease. Whereas the reduction in the heparin sulfate happens much faster.
Okay, silly question, but if you can just help put this into perspective for people who don't know, like how much would clinical trials cost?
Millions and millions. Yeah. I don't know. Is it any clinicians, clinical, is Mark Walterfang here? Yes.
Can be close to $1 billion, depending on the nature of the compound, the nature of the population. So it's a fair whack of money.
Yeah, and it depends how many phases you have to go through as well, which is where that accelerated approval comes in. If they can gather enough data in one trial, then that's going to save a lot of money and time.